11 participants so far.
Prashant bhai?
बस अपने 1 मिनट में शुरू कर दे. Ankita, we can start in a minute now.
Okay, sir.
Do you have people on YouTube, Prashant bhai?
Yes, yes,
So are we good to go now, sir?
yes, yes.
Okay. So, all right. Good evening and welcome to one and all present in this session. I'm Ankita from Planet. Planet is very proud to be a part of this webinar as a digital partner. Now, I would like to present to you all a short video of Planet. Thank you so much, everyone, for all of your patience. Planet is India's largest live digital CME and doctors-generated medical content platform. Our website is www.planet.com, where we have lots of live sessions conducted by eminent speakers across the globe. And we have made wiki services, which is medical Wikipedia for doctors only. That also you can read in your leisure time. Now, we will invite all the doctors to visit our website. Without any further delay, I would like to hand over the session to Dr. Prashant, sir. So over to you, sir.
Thank you so much. On behalf of NNF Gujarat, I, Dr. Prashant Karya, Secretary NNF Gujarat, welcome one and all to today's neonatal Pathshala. I request our President, Dr. Dipen Patel, to welcome our today's experts. Thank you.
Good afternoon, dear friends. I welcome you all on behalf of NNF Gujarat. Today we have an expert interesting topic of tips and tricks for using high frequency ventilator in newborn. We know that when we keep baby on high frequency oscillator ventilator, the baby is usually in a critical situation. How to handle baby on high frequency? There are many ups and downs during this case. Dr. Sachin Shah, who is an expert, will help us to treat such patients. What are the tips and tricks what we can use during the management of such patients? Dr. Snehal Patel is a moderator of this session. She will help us in moderating this session. I request Dr. Prashant Karya to introduce our expert and moderator.
Thank you so much. So today, Dr. Snehal Patel, she is a EB member of NNF Gujarat from the Ahmedabad zone. She is going to moderate the session. She is a consultant neonatologist in KD Children Hospital, Ahmedabad, and her areas of interest are neonatal resuscitation and focus. So I request Snehal to introduce our today's expert and start the session. Thank you.
Hi. Good afternoon, everyone. High frequency oscillatory ventilation. We consider it as a magical ventilation when we are, coming across with a sick babies in form of bad MS, bad ARDS, congenital diaphragmatic hernia, or cases with MS and PPHN. In all these cases, when we are struggling to get a good oxygenation through a conventional ventilator, this HFOV is a mode of treatment which we choose in these cases. And often, when we are using this high frequency oscillatory ventilator, we are finding a troubleshooting. So we do have an expert with us who is going to discuss the tips and tricks to manage this troubleshooting and how to handle the high frequency oscillatory ventilator. So without delay, I would like to invite the expert for this session, Dr. Sachin Shah. Dr. Sachin Shah is a practicing neonatologist at Anand Children's Hospital. He is the head of neonatology at Anand Children's Hospital, Surat. It's a level 3 NICU, and he is heading the fellowship program in NNF and IIP since last 9 years in his hospital. Welcome, sir.
Hello, everyone.
Yeah.
So I think, can we start the session now?
Yes, please. He starts.
So, okay. So first of all, I would like to thank NNF, Dr. Dipen, Prashant, and the team for inviting me and giving me an opportunity to discuss some of the tricks about high frequency ventilator. HFO is basically very close to my heart because I've been using it since so many years now. And I always find something new in the machine whenever I put a baby on the high frequency ventilator. And as Dr. Snehal told, that is basically mostly people use it as a rescue mode. When the lungs are very bad, the baby is not improving on the conventional ventilator at that time. It is something like, koi humko bacha le. There is I call it that it is basically a Brahmastra in our unit. When the baby is not doing well on the conventional, we try doing all our things, whatever is possible, apart from ventilation and supportive care. And this time, the high frequency ventilator is something which comes to our rescue. So it is basically used more of a rescue, but I say that it is more of a rescue for the doctors and the team, so that we can have something extra when we are treating this type of sick babies. I will share some of my experiences and some basics of high frequency ventilator today. This is basically the baby on high frequency ventilator. See, this is a Sensormedics 31008. There are different machines which are available now. This is how a baby looks on the high frequency. Lot of noise, as compared to the conventional ventilator. It is a piston which is moving fast. You can see the vibrations in the baby's chest. This is what we call as the wiggle, or what is the vibrations what we see in the baby. This baby was a very sick baby, bilateral pneumothorax, is on the high frequency on the nitric oxide. And these type of babies we do see in our neonatal ICU, and these are the babies which do quite good on the high frequency ventilator. So we'll just try to see today how different is high frequency from the conventional. If you see that there is high frequency, it means it is using very supra-physiological rates. Normally, we ventilate a baby at the rate of 40 to 60, but here we ventilate the baby from 5 to 15 hertz. That is almost a rate of 300 to 900 beats, 900 breaths per minute. The tidal volumes which the high frequency delivers is very, very less, as low as 2 to 2.5 ml per kg, almost as good as a dead space ventilation. And this is the peculiarity of high frequency ventilator, that it deals with very less tidal volumes. So today I'll just try to brief about what are acute lung injuries. Why do we really need a high frequency ventilator? What are the lung protective ventilation strategies we use? I'm not going to discuss about the conventional strategies, but I will try to discuss about how different is high frequency as compared to the conventional. What are the knobs on the machine? How do we monitor the babies? What is the evidence supporting the use of HFO? And what is our experience of last about 18 years, say, about high frequency ventilator? So let us start with basic that high frequency is not something new. It has been there since about late 1980s. So it's almost more than 35 years now that people have been using high frequency. And there are different types of high frequency ventilator. There is a high frequency oscillator ventilator, which we all use here very commonly. Then there is the jet ventilator, which people in India do not use most of the times. And there is the flow interrupter. So today my talk is more related to the high frequency oscillatory ventilator because I have more experience using these type of machines. It is basically a CPAP machine with some vibrations. You saw that the chest was vibrating of the baby. So it is basically applying a pressure as per the disease process and then using the vibrations to wash out your CO2. So it is basically a CPAP with a wiggle. Commonly, the disease where we ventilate in neonatology is RDS, meconium, pneumonias, hemorrhages, and these all are the babies where they go on conventional ventilator and they do not do well. Then they need the high frequency. So, what is more important is that you should understand what is the pathophysiology of the disease for which you are using the high frequency. So, let us come down to very, very basic. That why do you really need an HFO? If you can do well with a conventional, you may not need an HFO. So, where does HFO come into picture? So if you see this is basically how a normal alveolar looks, and this is the disease alveoli. See, the normal alveoli is a well expanded alveoli, a very healthy epithelial basement membrane. You can see a very good endothelium. The basement membrane is absolutely fine. Surfactant layer is there, and you have a very healthy, well open lung. But if you talk about a preterm RDS, you talk about a meconium aspiration, you talk about a pneumonia, in all these diseases, there is significant problem with the alveolar opening. The alveolar volume is less. It may be related to the surfactant deficiency, or it may be related to inactivation of the surfactant. There can be significant damage to the membrane here. There can be gaps in this. There can be increased interstitial membrane fluid, leukotrienes and all inflammatory markers are there. A lot of neutrophils, lot of platelet aggregation. So basically, if you see that this is a disease alveoli where there are multiple etiologies going together. So whenever we ventilate a child, we should be aware at what stage of disease we are ventilating. Are we dealing with only a surfactant inactivation or surfactant deficiency? Or is there a component of infection? Is there a component of chemical inflammation related to meconium? So all these things are very, very important because the strategy of ventilation which we apply to the baby, the strategy of opening the lung is very, very important according to the disease pathophysiology. So you see that there is an acute lung injury. Either if we talk about preterm, there is surfactant deficiency or inhibition. It leads to alveolar collapse. We all are aware of it. And this is leading to hypoxia and hypercapnia. And we try to do it more with non-invasive ventilation, but we all know that in very, very small babies, ELBW babies, almost 50% of the babies do go on mechanical ventilation. So this is a sequence of events. I'll just show you a video about how the alveolar recruitment occurs. So this is a tidal breathing. When there is inspiration, you can see that the lungs, the alveoli are opening up. And then at the end of the expiration, you can see a collapse. So basically there is an opening of the alveoli and closing of the alveoli in each and every tidal breathing. So you can see this. So if you see it, if you plot it on the PV graph, what we do very routinely, you see that. So this is the inspiration. You see that your pressure starts building up. You go to the peak inspiratory pressure, you have a good volume at that time. And there is the expiration. So there is always a beaking. There is a little bit of hyperinflation there. And this is the expiration where your flow is cut short and then you come down to the end of the respiratory cycle. So at this part, when we saw in that video, there is a part where there is a little bit of alveolar collapse at the end of expiration. And there we want to apply PEEP so that the lungs do not collapse at the end of alveolar. That is our concept of using CPAP in all these type of patients. And there is always some amount of beaking or some amount of overinflation in each and every tidal breathing. So basically, we want to avoid these zones of injury where most of the injury occurs, either the zone of hyperinflation or the zone of atelectasis. So we want to ventilate somewhere in between here, which we call it as the safe zone. So basically, it is basically the respiratory failure leading to mechanical ventilation. And then we try to ventilate the child. And because of ventilation, there is some injury into the lungs, which will lead to edema, inflammation, surfactant inhibition, that we call it as ventilation-induced lung injury. So the high frequency comes into picture here where we want to decrease the amount of ventilation-induced lung injury, or we want to revert back the changes which has occurred because of the ventilation process. So we all know that ventilation-induced lung injury, there are multiple processes how it occurs: oxidant injury, the barotrauma, volume trauma, and atelectotrauma. So just in short about how this occurs. So this is a normal alveoli. And this is an alveoli which is completely collapsed at the end of expiration. So our target is to have an alveoli like this. But because of repeated closure and repeated opening of the under-recruited alveoli, it leads to severe atelectotrauma. So there is quantitative and qualitative loss of surfactant also, which may lead to this type of atelectotrauma. Barotrauma, we all know that we use more pressures, and with more pressures, the alveoli gets swollen and there is a very high chance of leak. We all see a lot of air leaks, pneumothoraces, pneumomediastinum, which is related to the pressure. Volume trauma leads to significant over-distension of the alveoli, which will damage the pulmonary capillary membrane. So there will be a lot of infiltrates, a lot of pulmonary edema, which is there, and which is leading to a significant problem in the lungs. So these are the ways where ventilation-induced lung injury occurs. And along with all these things, the disease process per se, along with the tidal breathing and the high distending pressures, will lead to volume trauma, barotrauma, biotrauma, which leads to the pathophysiology of BPD or PI. So this is basically how pulmonary injury occurs in a diseased lung. Part of it is related to the disease process per se, and part of it related to the ventilation per se. So basically, if you cannot prevent the injury sequence, then our target would be to interrupt the sequence of events. We cannot decrease the amount of surfactant deficiency which a preterm baby is born with. But at least we can try to interrupt the sequence of events related to mechanical ventilation. So HFO comes in this picture. It does not reverse the injury, but it will interrupt the progression of the injury. So I'll try to see how. So this is one video about how the recruitment occurs. You can see this is a collapsed alveoli. You are applying some good amount of pressure so that the lungs are opening up. Now you can see this alveoli are opening up. There are still some collapsed part of the lung. And if you apply more and more recruitment pressures, you apply increasing the pressures or mean airway pressure, what we do on the HFO, and then you can gradually open up the alveoli which are collapsed. This is another video which shows how a recruitment of an alveoli is done. I just want to show this video so that you just know what is going on beneath what we see in the patient as such. What is going on inside in the alveolar level. See, this is a completely collapsed lung. We start with a very low pressures. We start recruiting the lungs by increasing the mean airway pressure. And you can see that there are different alveoli which are opening up. Still, there is a lot of collapse here, but with an increasing pressure. So this is practically a PV loop. With an increasing pressure, you are seeing some of the alveoli which were collapsed, which are gradually opening up. So our target in ventilation is to open up the alveoli, open up the lungs, and we should have all the alveoli in a completely open stage. We should not be overinflating, because with overinflation, there is a risk of barotrauma, there is a risk of air leaks. So we want all the alveoli to be open and in the healthy state, which is very, very difficult to know when we are managing the baby clinically, because we will not know which alveoli is in a normal zone or which is coming into a hyperinflation zone. So long as you had a reasonable recruitment and then you started decreasing the pressure. You start decreasing the pressure and you can again see that the alveoli are again collapsing. You're reducing the pressure, you can see almost we just came down to the setting what we started on. So this is basically just to show that what is recruitment and why do we need recruitment. This is how the recruitment process takes place. This is the gross macroscopic level of the lung, and this is how we see it on the alveolar level. This is a collapsed lung. We are doing tidal breathing without any recruitment maneuvers. And now this is an open up lung along with a good recruitment. You can see all the alveoli are pink open up. You can see the lung volume here, which is better. So this is basically what occurs in recruitment. Once you open up the lung, then the lungs will function well. So this is what our target is, to keep the lung. That was in tidal breathing. This is what I see in high frequency ventilator. So if you recruit your lungs, then your alveoli will remain open in that way. And these are vibrations, the wiggles, what we see on the patient. This is basically how your open up lung or the patient on HFO after recruitment will look like. So in cut short, these things is just to show you that if you see this is a collapsed alveoli. You start with the recruitment process. You can see the lung, which is completely black, small lung, collapsed alveoli. You start recruiting, when start increasing the pressures gradually in a stepwise way. Your lung volume will increase gradually, and there you will have an improvement in the saturations. Your saturations will show you that your lung recruitment process is reasonably going well. So you're increasing the pressures, you're having a good reasonable volume. So this is a pressure of roughly a pressure of 16, and then you can have your saturations are improving, so your patient is going to improve. You still go on recruiting the process until you're going to 20, and then you have a very overinflated lung. Your saturations will start dipping at this point of time, or the saturations will remain steady. And then you start reducing the pressures now. You start reducing the pressures now. So basically now you are coming down. Now you're on a pressure of 8. Initially, you see that this was a completely collapsed lung. And now after a recruitment maneuver has been done, now at the pressure of 12, initially you were like this, now it is like this. You can see the change in volume. So this is after in the recruitment, and now you can see the volumes are here. Here your saturations will improve, and again you still start decreasing the pressure, you will again collapse the lung. So basically what we want is that after a recruitment process, we want to ventilate here, which is the safest position to ventilate. So basically it is open the lung and keep it open, that is important. And in conventional ventilator, you all know that there are swings in the pressures from PIP to PWP. So you always see this is the high PIP, this is the PEEP, and there is a huge swing in conventional ventilator. In high frequency ventilator, you all saw that there are only wiggles which are seen in the patient. The change in tidal volume was very, very minimum. So there are no drastic changes in the pressure. And after recruitment, we can basically ventilate the patient in a quite safe zone. So basically, this is where the conventional ventilator works. After recruitment, your HFO works here. So our target is to ventilate here to find out for each and every patient which is the safest zone to ventilate. Then only we will be helping the patient by not leading to any extra damage to the lungs. you saw that there was a very huge piston. So the change in pressures were very significant at the ventilator level. But if we compare it on the alveolar level, there is significant dampening of pressure of the high frequency pressures. You can see in conventional ventilator, almost whatever is seen here, 95% of the pressure is dissipated to the alveoli to the tertiary bronchus. But if you see in high frequency, there is significant attenuation here. Hardly 5 to 8% of the pressure which is at the machine level or at the endotracheal tube level will be delivered to the alveoli. So basically, there are very few movements at the alveolar level. So the changes in volume is very, very less. So with conventional, the alveoli receive the full pressure from the ventilator, whereas in HFO, there is minimal stretching of the alveoli, and therefore there is less risk of trauma. One more thing about pulmonary vascular resistance is that if your lung is collapsed, if you have an atelectatic lung, then the PVR is going to be high. At optimum lung volume, where a well-recruited lung, your PVR is going to be the minimum. And when you are hyperinflation, when you are having a very high lung volume, then also the PVR is going to rise. So whenever we are even ventilating a pulmonary hypertension, we should know that atelectasis and hyperinflation will as such decrease the pulmonary pressures. So now what is optimized lung volume strategy? It is basically to increase the lung volume above the critical opening pressure to the optimum and keep it there in inspiration and expiration. A lot of benefits, we know that it increases the VQ, decreases the VQ mismatch, decreases the atelectasis, increases the pulmonary blood flow, and definitely the shunting will decrease and you will have a better saturation level. And when the lungs are open, the saturations are better, the need for FiO2 comes down, and FiO2, decreasing the FiO2 is also a very important strategy of protected lung strategy. So recruit the collapsed alveoli, stabilize the alveoli during inspiration and expiration, prevent end inspiratory overdistension, reduce the oxygen concentration, and ventilate at the greatest compliance. These all things look very interesting on the videos, but on the patient, it is very, very difficult to know. You will never know that you are on the lower zone of the graph or you're on the highermost zone of the graph, and it requires very close monitoring on the patient side. So now coming down to high frequency, as I told it, it uses very high rates with low tidal volumes. It is basically a CPAP machine. It is just CPAP with the piston displacement of gas. And this piston displacement leads to the wiggles or the vibrations what we see in the patient, which helps in washing out the CO2s. There is an active exhalation. If I talk about the sensor medics, there are different machines, but in sensor medics, the inspiration and expiration is a very active process. It is the piston which pushes the gas inside and the piston which takes back the gas outside without the use of the recoil of the lungs. As I told, the tidal volumes are very less. And the lower peak inspiratory pressures for any given mean airway pressure as compared to the conventional. As I showed in the graph, that even the same mean airway pressure, the pressures with the lungs are being exposed to is very, very less. One more important thing about high frequencies, there is decoupling of oxygenation and ventilation. What is decoupling? By decoupling, I mean that during conventional ventilator, whenever we change one knob, for example, we are changing the PIP or we are changing the PWP, we are changing the flow rate. These all things will lead to a change in the tidal volume. It will lead to change in the oxygenation as well as change in the ventilation. So it is affecting the carbon dioxide and CO2 levels together. In high frequency ventilator, these two things are quite different. There is, I will not say that is completely different these things are, but the knobs are different. So if you are having a hypoxic respiratory failure, then basically our strategy of mean airway pressure and recruitment will take care of it. But if you have CO2 which is building up because of any other reason, hypercarbia, then the knobs on the high frequency is different. So this is just how to show you. I will just show you later on. Indications. Indications are any patient who is sick enough, not maintaining good on conventional ventilator would be an indication for HFO, where we use it as a rescue. So inadequate oxygenation that cannot safely be treated without potentially toxic ventilator settings, and thus increase the incidence of ventilation-induced lung injury. All units will have their protocols or their targets. These are rough guidelines. Anytime pressure requirement more than 30, FiO2 more than 60, and you're unable to wean the FiO2. A MAP of more than 12, PEEP of more than 8, OI of more than 12 to 13, 12 to 15, depends upon the units per se. These are rough indications. It is basically showing that you are requiring very high pressures and high FiO2 to get a good saturation. Other indications would be pulmonary hemorrhage and inadequate alveolar ventilation with respiratory acidosis. Anytime severe CO2 retention, high frequency is the machine of choice if rest of the parameters are okay. Now coming down to the types of machines what we have, over the last 10 years, there has been a significant increase in the number of different types of machines which are available. I am aware of these all 4 machines which I have used, and there are a lot of other machines also. Important thing is that you should be aware of the specific things about your ventilator, whatever machine you want to use, whether you want to use the SLE 5000 or you want to use the Fabian high frequency, which is available now, or you are using the gold standard, which is the Sensormedics. So I'll talk only about Sensormedics. This is how the gas exchange occurs in HFO. I'm not going into the detail, but there are multiple mechanisms of gas transfer, like the molecular diffusion, the laminar flow radial mixing, there is the Pendeloff effect, there is the collateral ventilation, cardiogenic mixing. These are all theories. No one knows which is the exact mechanism of how gas transfer occurs in high frequency ventilator. So this is a preterm child on the high frequency ventilator. And I just want you all to see how the vibrations look and how we will monitor these type of babies clinically. This is the baby with the central line. This is a baby with severe RDS. You can see the chest vibrating. You can see the abdomen little bit vibrating. And these vibrations, we call it as wiggles or the vibrations, which we have to monitor very closely. You are seeing that the hands and legs are not at all moving. There is no vibration which is visible here. So this is an optimum wiggle. We call it as the wiggle factor, which is optimum for this type of babies. The machine has very few knobs. Basically, we'll talk about those knobs. This is the Sensormedics 3100A, and it has a very strong piston diaphragm oscillator. The oscillator moves the gases in the patient and out of the patient. There is a knob for the mean airway pressure. There is a knob of amplitude, which are the 2 most important knobs in the high frequency ventilator. Practically speaking, it is very easy to use high frequency because you cannot manipulate a lot of things. There are only 2 things for oxygenation, only 2 things for ventilation. Frequency knob is there. We usually do not change it once we start. Inspiratory time, IE ratio, we usually do not change. Flow rates, we usually do not change. So out of the 5 knobs, there are only 2 knobs which will require a little bit of change. These 3 knobs almost are, in 90% of the patients, these are almost fixed from the start of ventilation. So basically, HFO is a oscillator. There is a piston which is moving the gases in. There is the bias flow, and then there is the endotracheal tube. Now, these are valves. The CDP valves are there, and different machine has different ways how to. But the circuit is a very rigid circuit if you have seen the high frequency circuit. So we come down to ventilation and oxygenation in HFO. For oxygenation, there are only 2 knobs. One is the mean airway pressure, and one is the FiO2. FiO2 is what your nursing staff is going to take care of FiO2, and your job is only to decide which is the optimum map for your patient. So basically, very, very easy to use, very difficult to implement in the patient because you will never know what is the optimum map at that point of time. Your baby would be on an optimum map at about 10 o'clock in the morning rounds, and after about 6 to 8 hours in the evening rounds, 4 o'clock, that same map, which was optimum, would come in the hyperinflation zone, and the baby would develop a pneumothorax. So basically, it requires a very, very close monitoring, very, very simple machine to use, but requires a very thorough understanding of the pathophysiology. So we talk about oxygenation. How do we start HFO? We usually start with the high FiO2, and we start with the mean airway pressure at least 2 to 3, which is higher than the conventional ventilator. For example, you are shifting a patient of a severe meconium aspiration syndrome. You had a pressure of 28/6, and on that the saturation was not maintaining. So you start with that was a map of somewhere about 12. So you start on HFO with a map of 14 to 15. So at least start with 2 to 3 above that, and you start the recruitment procedure. You have to increase the map gradually by 1 or 2 until you have optimum lung volume. What is optimum lung volume? Until you have a good saturation without a fall in blood pressure with good vibrations. How do you decide which is the optimum lung volume? Best thing is to always get an X-ray done. So increase in a saturation is the first thing, and second would be you get an X-ray done. You see the chest, the diaphragm should be at about 8.5, 9 levels, which will say that the lung volume or the lung expansion is good. So maintain that mean airway pressure until you have a good saturation and your X-ray is better, and then try weaning of the FiO2 until you come down to 50 to 60%. This depends upon the disease process. It depends upon the the duration of ventilation, and it depends upon how early did you start your ventilation. If you started a baby of preterm RDS on HFO ventilator, then you should be able to wean down your FiO2 to 30% in first 2 hours of your ventilation. If you have shifted a baby of severe meconium aspiration on a very high setting for 48 hours, and then on third day you are shifting to HFO, then it will not be very much easily possible to bring down your FiO2 to the first 2 or 6 hours. So it all depends upon how early did you start ventilation. This is basically just to explain. You start your ventilation here, you gradually increase your mean airway pressure until you get a good saturation. Then you try decreasing your pressure. You start with a map of somewhere about 14. You went down till 25, you got a very good saturation. On 27, the saturations were falling. So you start decreasing the map. You know that your saturation started improving after 14. So then you come down till about again till 16, 17, 18. If you're maintaining a good saturation, you will understand that this was the closing pressure. Then you again try bringing down, again recruitment, and then try staying somewhere here. So I will not explain these things in detail. There are good articles related to that, but the recruitment process does not take much time. For a new lung, for a fresh lung, it will take hardly 20 to 30 minutes. For a lung which has been in a disease process for a long time, it may take an hour or so also to get this process done. So this is just to show you the X-ray about before recruitment and after recruitment. This is a very classical a landmark article about HFO ventilation, how to recruit the lungs. I will not go into the details, but it is just to find out your pre-surfactant opening pressure, pre-surfactant closing pressure, and pre-surfactant optimum pressure. So this can be done on the patient. What is lung recruitment or a sustained inflation? This is another way to increase the oxygenation. Here you increase the mean airway pressure by 2 to 3. In term babies, you may go till 4 to 5 also for about 20 to 30 seconds. The purpose is that the alveoli which have still not opened up because of the pressure what you are using and giving a sustained influence for about few seconds might open up the collapsed alveoli. And then you can again bring down to the original map which we are using on the conventional. And this helps in opening up the rigid or the collapsed alveoli. Mode oxygenation, mandatory to get an X-ray done, because without X-ray it is very, very difficult to know what is your lung volume status. How are the infiltrates, whether you have done anything improvement after ventilation or not. So an X-ray is mandatory. Get the first X-ray after 20 minutes of the recruitment process. Your target is to have a reasonably well expanded lung, at least 8 to 8.5 spaces. Diaphragm should be there. If the diaphragm is between 9 to 9.5 spaces, sometimes with the recruitment, you will have a hyperinflation. Then try bringing down your pressures by 1 or 2 gradually. Ideal should be that an open lung does not require oxygen. So if you have recruitment process is okay, if you have recruited most of the lung, then your FiO2 requirement has to come down. This is a mandatory thing. I've seen people ventilating with an FiO2 of 100% and with a map of 8, 9, 10. It practically shows that you're maintaining a saturation with a higher FiO2 rather than with a recruitment process. And basically your purpose of doing HFO is to recruit the lung. We want to open up the lung and then keep it open. So whenever you are on a FiO2 of more than 60%, always think about whether your recruitment is okay or not, or there are other causes of hypoxia. You should try finding out those things. So when you're not able to wean an FiO2, either do a recruitment process so that there are alveoli which are still not open up might help with this. Second is increase the map according to the X-ray. You got a recruitment process, your X-ray was still suggestive of 7.5, 8 spaces. Again, try to increase your mean airway pressure till you get a good saturation. So increasing map gradually according to the X-ray is also one strategy. If you're not confident enough in the patient, then do multiple X-rays, X-ray at 20 minutes, 30 minutes, and then decide your optimum mean airway pressure. And third thing is to check for other causes. If the patient has severe pulmonary hypertension and you're treating only the lungs are okay, then you might have to need some pulmonary vasodilator. Think about those things. Ensure adequate intravascular volume and cardiac output. This is very, very important because you're using a very high intrathoracic pressure. So it might decrease the cardiac preload. So always do a functional echo, check your IVC, see how the cardiac contract is, and decide your inotropes accordingly. Closely monitor the hemodynamic status. What we have seen is that most of the time the patient is not maintaining good saturation. The unit by default starts with dobutamine, then dobutamine and adrenaline. Without any assessment whether the heart function is really affected or not. So ventilation and inotropes do not go hand in hand, and you always have to see whether your cardiac function is okay or not. Pulse oximetry is the most simple and easy thing to use when monitoring your saturations. You do not need a PO2 every time to wean off your FiO2. It is the saturations, your target saturation as per the disease should be very clear, written in your file, and your nurses should be guided accordingly how to wean off the FiO2. That was about oxygenation. We come down to ventilation, means removal of carbon dioxide. There are only two things here. One is amplitude. It is the piston which is moving. The pressure changes or the delta B, which is important. And second is frequency. Frequency is the breaths per minute. As I told you, amplitude, most of the time, 90% of the things we do it with amplitude. Frequency, we hardly change. So what is amplitude? It is basically the tidal volume. The change in pressure leads to some amount of change in the tidal volume. And that tidal volume, what we call it the VTHF, the tidal volume in the high frequency, it correlates directly to the carbon dioxide washout. The sensormatics does not have any flow sensor. There is no way to monitor the leak also. So basically, we do not monitor the we do not monitor the tidal volumes in the sensormatics. But the new generation of ventilators, what we have, they have a sensor and they can monitor the tidal volume. So we are aware of the tidal volume which is there now, and we can see the trend of the tidal volume. Frequency, as I told you, we start with some frequency, usually do not change it. So if you want to increase the stroke volume, is you want to increase the tidal volume. We want to wash out the CO2. It can be done by two ways. Either the amplitude is increased, means the piston with which the pressure was being delivered is increased, so that the wiggles are more, and you can see a higher tidal volume. So this is basically, see the one cycle. So if you are increasing the amplitude, it will become like this. This is shown here. So basically, the area under the curve, this is the tidal volume. The tidal volume is going to increase. So for washing out CO2, you have to increase the amplitude, which is very, very simple. For decreasing the carbon dioxide, you have to decrease the amplitude. So this is very basic thing what we do for carbon dioxide washout. Second thing is frequency. Frequency, the equation of frequency in high frequency is completely opposite to what we do in conventional ventilator. In conventional ventilator, when we want to increase the minute ventilation, either we increase the rate or increase the tidal volume. In high frequency ventilator, if you want to increase the stroke volume, then we decrease the frequency. It is something like this. This is the rate, this is the tidal volume. And by increasing the, by decreasing the rate, I am increasing my I time, I am increasing my E time. So basically the area under the curve which was covered is more. You can see this graph and you can see this graph. This was on a frequency of 10, this is on a frequency of 8. So you can see the area under the curve increases. The tidal volume increases when we decrease the frequency. And this is one way to help in CO2 washout, but it is hardly done. We hardly see these things. dCO2 is the diffusion coefficient of carbon dioxide. And that is important now because we are monitoring tidal volumes. If you see this diagram, this equation in conventional ventilation, minute ventilation is rate multiplied by tidal volume, which we all are aware. In HFO, the minute ventilation is basically frequency multiplied by VTHF square. So it is the square of the tidal volume, which is very, very important. So therefore, even a small change in the tidal volume will have a significant larger effect on the ventilation than the changes in frequency. So this is important. This is what we call as the dCO2. Amplitude, as I told you, it is the force and the distance which the piston moves, and it determines the tidal volume. More amplitude, more tidal volume, less amplitude, less tidal volume. And it is seen clinically as the wiggle. The rigid, the circuit which the high frequency uses a rigid one, and it is not the conventional circuits what we use for the conventional ventilator. Even on these type of machines where on the Fabian or even the SLE, the circuit for HFO is different. Conventional workers do not work optimum because the pressure is dampened and the mean error pressure is also less as compared to that. Wiggle, as we saw the vibrations, they are different with different machines. And so it is very important to understand your machine. The vibrations or the wiggles, what we see on the sensormatics is different as compared to the wiggles, what we see on the Fabian or we see on this SLE 5000. So basically you should know what your machine is and how does it correlate with your carbon dioxide levels. As I told you in sensormatics, there is no monitoring of tidal volume. So the wiggle factor, your staff has to be on the bedside monitoring the amount of vibration what you are seeing. So you have to reassess that after any positional changes. If the chest oscillation is diminished or is absent, then you should consider whether the compliance has decreased significantly, there is disconnection of the ET or obstruction, or there is severe bronchospasm. If you can see only a unilateral oscillation, then there is some problem. There is either a pneumothorax on the opposite side or there is the ET which is displaced. So you have to always monitor the wiggle. Amplitude selection, it all depends upon the type of machine what you are using. So I will not give a very clear-cut thing. But on the sensor medical, you will start with 20, 23. And at them, depending upon the wiggle, we increase or decrease it according to the CF vibrations and the blood gas analysis. We always have to monitor the carbon dioxide levels in the blood gas. The PCO2 will tell us what amplitude is optimum for the patient. So for any baby, we will starting on the high frequency. The smaller the baby, the higher the need for frequency. We are ventilating a baby 800 to 1 kilo. The frequency would be in the range of 10 to 15. Full-term child, baby with a weight of 3 kilos, 8 to 10. So the higher frequency for smaller babies. Adjustment in frequencies are made in the step of half to 1 only, but we hardly do that. So for ventilation, what you do? First, increase the amplitude. If this does not improve, then only we consider decreasing the frequency. Eye time depends how what you are using, but usually it is 1:2. So the inspirated time would be set at 33%. It brings down the ratio to 1:2. Most of the time we do not change this, but when there is significant carbon dioxide retention or the MAP delivery is not optimal, you may consider going up on the eye time from 33% to 50%. But this is hardly done, so I will not suggest you trying to change the eye time very frequently. So for a baby on the HFO, what are the things, what are the troubleshooting things what we can do? So if there is an inadequate oxygenation, atelectasis or poor lung expansion. So basically you still have a collapsed lung, your saturations are not improving a lot. What you can do, you can still increase the mean airway pressure gradually by 1 or 2 in every increment, or you can do a sustained inflation and then decrease after improvement. So this is basically a poor lung alveolar collapse. You have to recruit the lungs. Inadequate oxygenation with hypercarbia. Overexpansion on the chest X-ray and poor cardiac output. So this is basically, it is showing that you are in the hyperinflation zone. Your X-ray is suggestive of an overexpanded lung and you are having hypercarbia. So the thing would be decrease the mean airway pressure, bring down by 1 or 2 or still more, and see how the blood pressure behaves, see how the saturations do, and get a blood gas to check your PCO2. Hypercarbia without any lung issue. You are having CO2 retention. First thing would be increase the amplitude. If you're increasing the amplitude, you have come down to a maximum what your machine can deliver, then second thing would be to decrease the rate. Hypocarbia, the opposite. Hyperoxia, decrease effort. So they are just basic things what you do on the HFO. Do we need to paralyze the patient on the HFO? Not usually needed. Sedation, a good sedation and analgesia may be adequate. We sometimes put the babies on fentanyl infusion and a baby is very fighting a lot, but most of the times SOS sedation and analgesia is what is required. Neuromuscular blockade is rarely required. We hardly do that. With a HFO, it is very difficult to auscultate. It is very difficult to know how the breath sounds appear. So basically, it is important you get used to listening to the vibrations in the axilla, whether there is symmetry of the piston sounds are there or not. And if there is anything abnormal, you can get an X-ray and check for the things. If you want to listen to the heart sounds or you want to listen for murmur, you have to stop the piston. This is possible in sensormedics, but not possible in other machines. So you can stop the piston, you can stop the oscillations, you can listen to the heart sounds, and again you can continue with that. Chest X-rays, as I told you, start in the first X-ray in 20 to 30 minutes after initiating HFO, and then as it when required. But even if everything is okay, at least 1 X-ray in 12 hours is mandatory. You might need more X-rays when the condition changes. And many times in the initial phases when the patient does not maintain good saturations, you might require more frequent X-rays in the first few hours of life. So that is equivalent. And what you see in the X-ray, always look for whether the position of endotracheal tube is okay or not. Rib expansion, your target should be 8.5 to 9 spaces. Look for air leaks, look for the change in lung disease. You see how the infiltrates are behaving, whether there is clearing of the infiltrates, the haziness is decreasing or increasing. You see for the heart size. If you are having a small heart size, it is suggestive of a overinflated lung. You see where your diaphragm is. ABG monitoring, there is no way to know what the carbon dioxide levels are in HFO ventilation, because if you do not have tidal volume monitoring, it becomes very difficult. So an initial ABG at 20 to 30 minutes after starting of HFO, and then 8 to 12 hours as and when needed. What our experience says is that in the first day or so, you do require more frequent blood gases, but then later on, with a good assessment of the vibrations, the amount of amplitude what is needed, then you can decrease the number of blood gases required. PCO2 monitoring is important as HFO can lead to severe hypoventilation. Sometimes if you do not do blood gas, I have seen PCO2 values in the range of single digits also. So it is very much detrimental to the overall long-term outcome. So ABG monitoring is mandatory. So if you do not have an X-ray machine or ABG machine, do not plan to get a high-frequency ventilator. Transcutaneous CO2 monitoring, if it is available, it is very useful because then you will not need to do a lot of blood gases. You can see the value of CO2 and you can see the saturation, which will help you in knowing where how you are ventilating. As I told you, DCO2 is basically frequency multiplied by tidal volume square. That is the carbon dioxide diffusion coefficient, and it can be monitored in newer ventilators because when we are monitoring the tidal volumes, the DCO2 value is there. And what is important is the trend of DCO2 is important. One single value for one patient may not be the most important thing, but if you see a trend of DCO2, and that trend will help you in knowing how your CO2 levels are there in the blood gases. Suctioning de-recruits the lung volume. You all know that once you open up your patient for suctioning, the amount of recruitment what you did with the pressures will all go. So basically, try using a closed suction system. This is useful even for the conventional ventilator. And after suctioning, you might need to use sustained inflation maneuver so that you can again reopen the alveoli which you lost the lung volume because of suctioning. Weaning, so you ventilated the child, you have done adequate recruitment, you bring down on your pressures, your FiO2s, and your amplitude is minimum. And so now this is the time to wean of the patient. So once your goals of adequate ventilation oxygen are achieved, it is usually when you're bringing down your FiO2 less than 30, map of 6 to 8. On a full-term baby, the map of 8, 8.5 is okay to extubate the child. For bigger babies, you can directly extubate to room air or to hood oxygen, whatever is needed. For smaller babies, you can shift them to a CPAP machine. From HFO to conventional ventilator is not something which is done very routinely, and we hardly do that. You usually extubate these babies. And now, with our experience of using nasal HFO, we are extubating these babies from invasive HFO to the nasal HFO. And still our experience is not a very huge experience, but now there are more and more trials coming of nasal HFO. What are the complications of HFO? It's a very strong machine, so you have to monitor very closely. It can have a significant increase in intrathoracic pressure, so you might need some volume resuscitation or some inotropic need would be there. So always evaluate, do a functional echo bedside. Pneumothorax. Initially, we used to blow a lot of babies on HFO. Whenever we started with HFO, our nursing staff would keep our drum of ICD ready also. But now, with experience and with so many patients being treated on HFO, now we know that. So the incidence of pneumothorax comes down. Migration or displacement of ET. This is something which we have seen only in HFO. Your ET would be very well positioned, but then after 12 hours of X-ray, you see that the ET would be a little bit up. This is quite common what we see in HFO ventilator. So you have to monitor for the position of the ET. Bronchospasm, it is possible only if there is no adequate humidification. So humidification is very, very important because the displacement of gases is very high. Mucus plugging, secretions, hemorrhage is all related to humidification. Necrotizing tracheobronchitis is written in textbooks. We haven't seen as such, but for babies who are on a long time for HFO on HFO ventilator, then this has to be monitored. Increase IVH and PVL. These are for the older patients when before about 25-30 years when there was a lot of hypocarbia related to HFO ventilation. And in these patients, there was trials of increase in IVH and PVL, but we don't see it now. What is new now? We have volume guarantee with HFO. We have the newer machines which give you a volume monitoring, and now we have machines which give volume guarantee with the high frequency ventilator. So you fix up your volume guarantee, what we do in the conventional ventilator. In conventional, we put it at 5, here you put it 2 to 2.5 ml per kg. You put a volume guarantee on, and then the amplitude will change. The machine will decide which is the best amplitude to deliver that much amount of tidal volume. And with that, it is supposed that the changes in CO2 values would be better. But a lot of trials are there, a lot of trials still going on. We don't have good big systematic review related to that. But some trials it is proven to be useful. In some trials it is still not proven to be useful. Still we might get better and better reviews later on about this. So clinical management, what I would see that HFO works best in a diffuse homogeneous lung disease. When you have a bilaterally symmetrical bad lung, in those conditions, HFO works very well. Either it could be RDS, it could be severe pneumonia, ARDS, pulmonary hemorrhage, but in these cases, the recruitment process can be done very well by the HFO, it works well. In non-homogeneous disease like an asymmetrical lung disease like a meconium or lobar pneumonias, there the use has to be a little bit tricky, because in recruiting the collapsed lung, there is a very high chance that you will blow out a normal lung. So very high chance of air leaks and pneumothoraces if you are not monitoring the child well or you're not recruiting properly. So this has to be taken care of. Then there are the lung hypoplasia syndromes like diaphragmatic hernia, pulmonary hyperplasia, air leaks. In all these babies, we will use the low volume strategy. It means we will not use a very high mean airway pressure. You will use HFO with a volume equivalent or less than the conventional ventilator, and it works well in these type of diseases also. In diffuse homogeneous disease, you start with a MAP 2 to 3 or 2 to 4 above the conventional. Frequency for preterm 10 to 12, 12 to 15, and for term babies about 8 to 10. And amplitude, we start with 20 in preterm, 25 in full-term babies, and it all depends upon how the chest wiggle is. And then you decide according to the blood gases. So what are the strategies on HFO? Early intervention, proactive, or rescue? Rescue was the older way when people used to use HFO only as a last resort, when everything was done. It was just before dying that the people would shift a patient from conventional to the HFO. Either the baby did not maintain good saturation, had developed significant air leak, and then transitioning to oscillator means you have developed significant amount of ventilation-induced lung injury, and then HFO will not work. So the results were not very much encouraging in the initial part of 90s when HFO was started and comparing with conventional ventilator. Proactive is basically the early rescue, what people are using now. It is basically a term applied to the infant on the conventional that reaches specific threshold and is then transferred to the HFO prior to the onset of barotrauma or air leak. So basically before a significant damage has occurred, you're shifting the patient to HFO. So this is basically the early rescue, or what we are using, most of the units are using now. The results are better. The guidelines would be institutional. The general guidelines, MAP more than 12, OI more than 15, or detracting fast, FR2 more than 60, as I discussed here. For a small baby or preterm baby, PIP requirement according to the gestation, as good as the gestation, would be an indication. For example, a 28-week requiring a PIP of more than 28 can be shifted to HFO for better lung recruitment. Early intervention, very few centers in the world are there which are using high frequency as an early intervention. That means you are using HFO, intubating the child, immediately putting the patient on HFO ventilator, or as early as possible in the first 2 to 4 hours of life. So a lot of trials are there, a lot of articles are there, and a lot of good units which are having a very good experience with HFO is there, and the results are excellent related to that. Evidences, not have much time, but I'll just brush up what are the basic things. The older trials of 90s showed a high incidence of air leaks and abnormal neurodevelopment, but the trials were not very well powered. The strategy of ventilation was not very good, and that was the reason that the results were not very good. But then later on, people understood that it is the open lung strategy which is important, and then a lot of trials in preterm, full-term babies were there. This is a systematic review of elective HFO versus the conventional ventilator for acute pulmonary dysfunction in preterm infants. The review was in 2015. You can see death or BPD, almost same, but a trend towards favoring HFO. BPD at 28 days, trend better in HFO. Air leaks more in HFO, does not favor HFO, better in conventional ventilator. Gross air leak, it is almost the same. IVH, same. ROP, there is significant improvement in ROP. If you see this systematic review, the values is also very, very significant. So in HFO, the incidence of ROP is less. Another review about full-term babies. This was about the preterm babies, about full-term babies. Comparing HFO with conventional ventilator, a lot of other articles. I will just go into the detail. I will just see that neither the trial showed any reduction in the mortality at 20 days or in failed therapy on crossover. No difference in pulmonary air leak, chronic lung disease, or intraocular injury. And so more trials are needed. But in HFO, no difference in the days of ventilation or days in the hospital. So basically, we need more trials to prove that HFO is better than conventional ventilator. Lot of trials comparing conventional with HFO for reducing death or BPD are also there. Some articles suggest very significant improvement. Some articles do not suggest a good improvement. And that is basically where the skill of using HFO lies. There are a lot of trials in full term also comparing volume control ventilation with high frequency ventilator and volume guarantee, but still we do not have a very concrete systematic review related to that. Diesel HFO, as I told you, it's a newer mode of non-invasive ventilation. Now we are very much used to using CPAP and nasal heated high flow nasal cannula. Nasal HFO is one of the modes which can be used. Lot of articles, lot of evidence is coming, comparing it with other modes of non-invasive ventilator, but still not proven to be better than CPAP or HFNC. What we are using is an early RDS or post-extubation settings. We are using it more. Complications have to be monitored. Lot of articles, lot of still trials going on, and we still do not have a very clear-cut consensus. So basically, I still have more questions today rather than having more of the answers in high-frequency ventilator. Is there a specific population of preterm infant at risk of CLD that would benefit from early HFO? We are not sure, because a lot of articles in some centers where they have seen that the incidence of BPD is less with early HFO, but no concrete systematic review still suggestive of that. What are the effects of elective HFO compared to conventional when used as an early rescue? Means using it as early as possible. Once your CPAP is failing, you put the patient on HFO. We do not have these type of trials at this point of time. Are there differences in pulmonary outcomes and adverse effects by type of ventilator which are used to generate HFO? We are not comparing HFO from different types of machines, from the Sensormedics, from the Fabian, from the Draeger. So still there is a significant difference in those things. Long-term neurological and pulmonary follow-up data from the trials are still limited. So we still want to know how does these type of babies on conventional HFO do in the long run. Are there difference in the cost compared to the benefits of HFO? People have not done any trial, but what we see is that it is more cost effective because the days of ventilation are less. So there are more and more questions. So basically, so there is no clear-cut high frequency. There is a standard of practice. This is the standard protocol. This is how you do high frequency ventilation. There is a significant variability in application of HFO in different units. There are different units using different machines, and their strategy is different. So the best machine is yet to be identified. I have used a lot of machines. If I talk about my experience of using HFO, it has been very, very exciting. Almost about 1,000 babies we have ventilated on HFO. Most of the babies are on the Sensormedics, and we have an experience of using the SLE 5000 and the Fabian HFO also. What we have seen is that it is safe to use. We have hardly seen, in the last few years, we have hardly seen very significant amount of hypocarbia or a lot of air leaks as compared to conventional. It is basically learning the machine and the art of monitoring the patient on HFO. Your staff has to be trained properly about monitoring the wiggles, monitoring the saturations, and knowing how to interpret the X-rays. That is very, very important. It is very useful for a bilateral diffuse lung. It works very well with nitric oxide in patients of severe PPHN. Conventional plus INO or HFO plus INO. HFO INO gives very excellent results in severe PPHN. It is an excellent machine for removing CO2. You put a patient on HFO, increase your amplitude, within 20 minutes, you will get an PCO2 from 100 to 55. Very powerful machine. So have to be monitored for air leaks and CO2. What we have seen is that the cost of ventilation is very, very less because the days on ventilation decreases significantly. If you compare it, the days on ventilation on conventional HFO, there is almost about a 40% cut in the hours or days of ventilation. The earlier you start, the better are the results. It basically saves life. It is our Brahmastra in our unit. And everyone knows that if something does not, the patient does not improve, it is always the HFO which will be tried as the last resort. So it basically train your team the art of HFO. So I will just try to end up that any newborn is a demanding individual. Whichever methods of ventilation you use, clinical observation, bedside vigilance, timely action, human touch and tender care cannot be replaced by any technology. So basically clinical monitoring is the most important part. And our principle of ventilation is first, do not do any harm. So it is a very attractive and a very a fascinating machine, but until you and your team is very much clear, confident in using it, you know you have the resources, you have a blood gas machine, you have an X-ray, and then only try using these type of machines. So I will end the talk by keep questioning. Thank you.
Thank you very much, Dr. Sachin, for a very nice and elaborative discussion on high frequency oscillatory ventilator. I'm asking any questions from the audience side? No question. So till then, I want to ask you, you have used nasal HFO in some of your patients. So I was just wondering, when we are using a nasal HFO, when a baby opens the mouth, is there a de-recruitment problem in this nasal HFO which we are coming across? Because for the ET we are using a closed suctioning, considering that it may cause a de-recruitment.
So basically, what our experience of nasal HFO is there, we are not using as a primary modality for lung recruitment. We are not using it in the initial part of RDS when we are not using it in place of CPAP. But what we have our experience is that after extubating these type of babies, either putting them on nasal heated high flow HFNC, we try using these type of patients on nasal HFO, and sometimes the vibrations and the CO2 levels are better in the nasal HFO as compared to the either HFNC or the CPAP machine. So that was one way only to start whether this can work or this cannot work. I do not have a very lot of experience in starting nasal HFO as the initial mode of therapy. Till non-invasive CPAP would be the first thing what we are still using at this point of time. But I would be interested in seeing articles or trials about using nasal HFO as a recruitment way compared to nasal CPAP.
Right. Sir, another question from my side is, at what delta P, if the PCO is high enough and you cannot change your delta P, you have to come down on a frequency?
See, basically it depends upon what machine you are using. If you see the SensorMedics, the SensorMedics has a huge range of amplitudes. So on the SensorMedics, it is very unusual that you will use an amplitude of 70, 80 which the machine can easily deliver. And even on 70, 80, you will have a CO2 retention. That is practically not possible. It can be possible because of the disease process per se sometimes, and then we do bring down the frequency by 1 or 2. But
we may reach up to 50 or 70 of delta P, sir, you are telling?
Yeah. You can
in the neonates as well?
You are used to 75 also.
Okay.
When babies who are less than about babies 1.5 kilos also. It requires very close monitoring basically. You have to monitor your CO2 because you never know what the CO2 levels are. But one more important thing what I would suggest is that always check for the size of ET. Because sometimes we do not monitor the ET leaks in SensorMedics. So if your ET is of a small size, the resistance is going to be very high. Then you can have significant CO2 retention. So what we have done is that if we have a chance that we can put a bigger ET, we replace the tube with a bigger size tube, and then we see how the amplitude works on it.
Right. Okay. Sir, so I have a BN600 and we are very happy with that. You have used this 3 machines, SensorMedics, Fabian and Acely. So in which machine you're more comfortable with, static and INO? Because the people are saying in SensorMedics is better to and more compatible when we are starting in INO.
Anytime SensorMedics will win in our unit, because I think our experience is more of using that machine. We have 4 SensorMedics, so anytime it is always a SensorMedics what we start using it. And we have also shifted babies from the SLE to SensorMedics, from the Fabian HFO to the SensorMedics because of 2 things. One is that the amount of amplitude what these machines can deliver is far less as compared to what SensorMedics can deliver. And second thing, what we have seen is that the map delivery is very, very significant in SensorMedics. Sometimes we shifted a baby on a map of 20 from the Fabian HFO, and then we had to use a map of only about 13, 14 in the SensorMedics.
Right.
So basically, I'm not sure what is really going inside at the alveolar level. We are not sure what is going on because we always monitor the X-ray and blood gases and the saturations. But what we have seen is that SensorMedics uses a map which is quite less as compared to the other machines. And there are some articles related to that about the delivery of mean airway pressure, because mean airway pressure is not being monitored in the sensormatics. It is only what the machine is delivering at the machine level. We do not know what is being delivered at the alveolar level. So we still need to monitor a lot of that things. But for our unit, definitely sensormatics is there. Even with nitric, we have used only sensormatics. Initially, we used to use SLE 5000, but now I think it is almost compulsory that whenever we want to use INO, we shift the baby to the sensormatics.
Okay. So there is a question from audience. They are asking, is there any specific strategy while dealing with a bad lung due to hemodynamically significant PDA and in cases with the PPHL?
So basically, these are two different things which are going on together. You have somebody snoring basically.
What is, yeah.
See, when you have bad lung, whatever the reason would be, you will need to recruit your lung. So either your strategy of recruitment will remain the same, whatever you want to do. You are increasing the pressures gradually. That is the thing what you will want to do. And about PDA, it's a different thing. You will treat your PDA accordingly. So I always say that you do not consider HFO as a different machine as compared to what you have been doing on conventional ventilation. It's just a way of ventilation. You just have to learn that way of ventilation. And if you are confident in using that, the strategy remains practically the same.
Can we identify who is snoring?
Sir,
is there any experience of using is there any machines available for high frequency ventilator machine, high frequency oscillator mode on a transport ventilator? Because sometimes we are getting the call, the baby is on high pressures, and we want to shift the baby. So in those cases, is there any mode, is there any newer modalities available for the transport ventilators with HFOV?
See, I'm aware of some transport ventilators which can deliver HFO. I have not seen it in India, but I have seen some machines abroad where they have the transport ventilator which can deliver a flow interrupter HFO. So, but I don't have any personal experience. I have not seen it being used anywhere here.
Right, sir. So in all these babies, how do you transfer? Transfer to your unit?
These type of babies being shifted, the babies will be transferred on the conventional ventilator only, because we do not have the HFO during transport, and the sensormatics does not work well in the ambulance because it requires a very high bias. So basically, we transport these type of babies only on the conventional way, how we do it, and then in the unit we shift them to the HFO.
Right.
I think I have a question. Is there any kind of upper limit for MAP in HFO? Like 30, 35, 40?
See, I think there is no limit for any numbers basically. It is all according to the disease process per se. Basically, we have used a MAP of 25, 28, 30 for a baby who is 1 kilo, 1.1 kilo. It looks very astonishing, but using a MAP of 28 for about 48 hours for a baby who was almost 1 to 1.1 kilos, who had a severe pulmonary hemorrhage and sepsis, and we required this much amount of MAP for about 24, 48 hours. So there is nothing like what MAP is high basically. It is just that if you are requiring a very higher MAP for lung recruitment to maintain a good saturation, your monitoring has to be more vigilant. You have to get more X-rays done. You might get an X-ray every 3 hourly, 4 hourly. You might have to do more frequent blood gases to see how your CO2s are. So that monitoring is more important, but the value is not important. What I would want to know that every time you see your X-ray, what is the lung expansion, and then you decide which is the best for you. Don't see the number, what MAP you're on. Either you're on 10 or 12 or 25, doesn't make a difference. Your target should be to get a good saturation, and you should be able to bring down your FiO2. That is what is important.
So, in cases with the PDAs and all, where we are concerned for the fluid restriction, we are keeping this much of a MAP, and our venous return is getting compromised. So how do you deal with this kind of a situation?
Basically, what we have seen is that if you are using an optimum MAP, then your venous return is not going to get compromised. If your baby requires a MAP of 15, then you have to give 15. It is not that a MAP of 15 will lead to decrease in venous return. If your lungs are bad, you will need that much amount of pressure. Your venous return will get hampered only when you are in the hyperinflation zone. So basically, you are using a MAP which is more than the optimum. That is the only case when you will see that your venous return is compromised, or you will need to start on some fluids or inotropes. So what we have seen is that basically you just have to get some more X-rays. If your X-ray is showing 8.5 space of expansion, then you will not think that this is the reason for having a low blood pressure or your perfusion is hampered. That could be some other reasons related to that. But ventilation is not the cause for that.
Doctor.
Regarding cost of sensor medics circuit, I think it is very costly as compared to the Fabian or
Yeah.
So how do you take care of this cost when you use sensor medics?
See, basically, we are doing ETO of these circuits. We put them in SideX for about a day, and then we ETO the circuit. We use it for 4 or 5 times. One circuit, a complete circuit, is going to cost somewhere about 45,000.
Right.
So this is the way what we are doing it. Many times we have done some cultures from these also, and they are quite okay. So we are using the circuits. But for babies who are having significant sepsis, then in those babies we discard the circuit. But otherwise, you are using one circuit about 4 to 5 times definitely.
Because many times application of the green and red buttons, they usually leak the air. So how do you troubleshoot those problems when you use sensor medics?
Yeah, see, basically the best is always the new circuit. And in older circuits, what problems you will have, there will be some leak somewhere. So there will always be some leak of pressure would be there. So your map delivered would be a little bit less as compared to that. Then what we have seen in older circuits is that the piston centralization is also not proper. Because the rigidity of the circuit is different from different level. At the piston level, it will be different. From the ET level, it will be a little bit different. And there is a lot of molding also. You see, the circuit is a rigid straight circuit. So in the older circuits, definitely you're going to have some problems. And if it doesn't work, then definitely it is always the new one which has to be used. But what our experience says that we usually are using it for 4 or 5 patients and quite okay without any major issues in that.
Right.
Fine. So no more questions, I think. Yeah. There is a question from Dr. Kamil. And he's asking give me some information on use of surfactant with HF.
I did not get you. I don't voice is going along.
Hello. Am I audible now?
Yeah.
So there is a question from Dr. Kamil. And he's saying give me some information for the use of the surfactant along with HF.
Surfactant with HFO can be in the same way what we did. There have been trials that do a recruitment on the HFO and then you give surfactant, then the results of surfactant are better. The hours of ventilation is less. So basically there are articles. And am I audible?
Yes, you are audible.
Okay, so there is some change in speed. So basically with surfactant also you can use HFO. If you are recruiting the patient, you're ventilating the patient on the HFO, then the effect of surfactant is going to be better. So always surfactant can be used without any issues. But how you give surfactant is important because while giving surfactant, there will be complete de-recruitment of the alveolar what you have recruited. So that is going to be a problem. But then after one recruitment, give a surfactant, then again ventilate and then recruit the rings properly. That should be okay.
That's it.
Fine. So I think it was a nice discussion. Yeah. So on
Thank you so much.
Yeah, on behalf of NNF Gujarat, we thank our moderator, Dr. Snehal, and expert, Dr. Sachin Shah, for giving tips and tricks for using high frequency ventilator. May I request Ankita to present a certificate?
Yes, sir.
Yeah. So on behalf of NNF Gujarat, Dr. Dipen Patel, President, and Dr. Prashant Karya, Secretary, we present a certificate of appreciation to Snehal Patel for moderating a session. The lesson from experts, tips and tricks for using high frequency ventilator. And we also thankful to our expert, Dr. Sachin Shah. Next slide, please. Yeah, for being an expert in neonatal Pathshala.
Thank you.
See you next Wednesday in same neonatal Pathshala, 3:30 p.m. by using same link. Thank you so much.
Thank you very much.
Thank you so much, everyone. Hoping to meet you again on the platform very soon. So with all your permission, let's conclude the session over here.
Yeah.
Thank you.
Thank you.